Fantastic. Okay, so welcome to another edition of Machine Medicine's interview series, and we are delighted and privileged to have Priscila Giacomo Fassini, who's a professor at the University of Sao Paulo, here to talk about her work and related works in non-invasive neuromodulation in the context of young women with obesity and just more generally in the context of sort of eating disorders and stuff. So thank you very much for being with us, Priscila. And as usual, it would be fantastic if you could give us a short introduction to your sort of background, how you got into science, how you got into this area in particular, and why you decided to sort of focus on this relatively niche area of neuromodulation, arguably, although very exciting and growing very rapidly.
Great. Thanks, Jonas, for the invite. It's an honor for me to be here today and talk to you, to share a little bit of my work. As I said, I'm a professor at the University of Sao Paulo, that's in the southeast of Brazil. I am a dietitian with research experience and clinical practice focused on clinical nutrition. So I have been working now on evaluating the efficacy of tDCS, or Transcranial Direct Current Stimulation, which is non-invasive neuromodulation, to improve eat control in women with obesity. And we know that obesity is a very complex disease, multifactorial, and the prevalence of obesity is increasing at alarming rates in many countries. And the epidemic of obesity is now recognized as one of the most important public health problems facing the world today. And the most widely recommended therapy for obesity is lifestyle modification, which includes diet and exercising. That sounds to be easy, but it is not. Actually, implementing change that can lead to weight loss is difficult. And maintaining long-term weight loss is even more challenging. We know that more than 80% of people who start a diet regain weight, they need a weight loss or even more. So we are talking about a very complex and important disease that also a pandemic. In the actual scenario, you need to have a sort of academic effort to start to look at this and try to understand better to figure out new ways of treatment. So the control of food intake is also highly complex, involving neuronal, hormonal, and nutritional control. And individuals with obesity, they show a decreased activity in the prefrontal cortex, which is a key brain region supporting eating behavior regulation. So recent evidence in the field of obesity and the brain-based integration indicates a potential for designing new therapeutic strategies of an intervention, because we needed to try to understand and have new ways of treating these patients. So in this context, the non-invasive neuromodulation of brain activity has been shown in the literature to be a technique that could help reduce food intake and actually appetite and food craving that also can lead to reduce of food intake and body weight. So tDCS targeting the dorsolateral prefrontal cortex could reverse these abnormalities and maybe a potential benefit for people who are trying to lose weight. Because, yes, it modifies the cortical stability and may facilitate and improve it of eating control. However, we have limited studies in the literature now, and then most of the studies are short-term studies and present a very high variability between individuals.
That's fascinating, Priscila, and there's a lot in there. I wonder if I can get you to just sort of back up a little bit for some of our listeners, and talk a little bit about, so for example, the dorsolateral prefrontal cortex. You mentioned that it's been implicated in appetite and eating and so forth, but actually there's a very broad and varied literature on this area. And can you say a little bit about the kind of the kind of functionality that the dorsolateral prefrontal cortex has been associated with it with previously? I mean, another way of putting the same question might be, why do we think this is a good place to stimulate or inhibit or whatever it is, in terms of a kind of mechanistic kind of understanding? What do we think is going on here that we're trying to change?
That's great question, Jonathan. That's so the target area of the brain that we are looking at stimulating is related to cognitive control. So we know that people with obesity, they have impairment of this function. So it's not because they don't want to follow a diet or because they are they do not understand it, but it's because they have real difficulties related to impairments in the brain network that lead them to have a poor cognitive control. So so when you look at the brain of obese people compared with lean individuals, we can see this difference of activity in this area of the brain. So we think that, oh, maybe if we try to reverse these abnormalities, could we help these patients to have more control of the food choice they are going to have? And maybe this could help them to lose weight. That is like what we think, and this is our hypothesis. So maybe if we reverse these abnormalities in this area, could we help them? But the real mechanisms behind all this is still unclear, because we know that brains are very complex, and also regarding all the networks. And I think we still need to learn a lot. Most of the studies published until now are focused on the left or the right side of the dorsolateral prefrontal cortex.
Interesting. And why do we think, for example, somebody might wonder, why haven't we developed a drug to treat obesity? What do we think what are the problems with sort of pharmacological treatment? Would you, in your judgment, that mean that we have to take, arguably this sort of more extreme step of actually trying to directly stimulate neurons?
Yeah, there are options of pharmacological treatments and also surgeries. I think what is right for everyone, it really is very individual. But also we have seen some studies associating tDCS with other strategies. I think that would be future of the field, because associating tDCS with hypocaloric diet, that's what we did in our study, or associating tDCS. We're seeing studies like associating the JAMA publication, associating tDCS with medication and pharmacological therapies, looking at depression. So yeah, I think we need to explore not just looking at tDCS alone. We did tDCS only in our study, but also in association with other therapies to see if they could improve the therapy that we are looking for.
Fascinating. And is the thought behind that we could somehow, when you say associate, is the thought there that we could somehow take advantage of the brain's natural capacity for plasticity in order to sort of place the brain into a healthy, as it were, a healthy state, or the diet into a healthy state, and then use neuromodulation in order to elicit plasticity that would hopefully sort of solidify that change?
Exactly. Yeah, that's what would be great. So in our study, we were looking at investigating the effects of a nodal tDCS over the left dorsolateral prefrontal cortex in young women with obesity over a period of 12 months, because we do not have studies following these patients after the intervention. That's, I think, is the question. So do we need to stimulate these people to see these results, or we can, how they low? So I think we need more studies looking at the follow-up period. Like this was the first study we published, our first 6 months follow-up, and we followed these patients until 12 months. So we did like a 3-phase intervention. So phase 1 was target engagement. We are looking at the only single section of tDCS. During phase 2, the patients received 10 sections of tDCS from Monday to Friday to 2 weeks, during 2 weeks. And after this period, they were admitted in our clinical hospital to follow a hypocaloric diet in an inpatient setting to reduce compliance. Then we can make sure that the diet is really is a supervisioned diet. And also associated with tDCS. So we have like these two phases of the patients, the volunteers completed a month of an intervention, and after this period, we followed them over 12 weeks. So what we saw, so we did like, it was a randomized and double-blind controlled, sham controlled. So we have a group receiving real tDCS and another group receiving placebo. So what we saw after intervention, and also I'd like to highlight that the hypocaloric diet, not like a restricted diet, is what we really recommend. So we measured individually the resting metabolic rate based on direct calorimetry. So after determining the total energy requirement, we reduced 30% of energy intake. And also the macronutrients of this diet was balanced, like normal distribution of carbohydrates, protein, and lipids. So what we saw in this intervention, that we didn't find, contrary to our hypothesis, so active tDCS did not promote beneficial in the weight loss in the active group. So both groups, sham and real tDCS, reduced 3% of body weight at the end of the intervention. And also during the follow-up, the volunteers receiving real tDCS, they lost less weight, and at 6 months they started regaining weight, and at 12 months they regain 3% higher compared to baseline. So this was very interesting. And then when we start looking at the genetic variation associated with this result, then is what we saw, like our striking, I guess this is our striking result of our clinical trial. Because we know that there is evidence that the effects of neuromodulation is affected by dopamine. And we know that dopamine is related to food reward and feeding and body weight. And so what we did, we investigated a variation in the gene HONT, which encodes an enzyme that's responsible for the degrading dopamine in the brain. So it's related with the dopamine availability in our brain. So what we did, we characterized our volunteers as carriers and no carriers of the MET allele of the CONT gene, because there is a single, there's a polymorphism called valine 158 methionine that affects enzymes, so it makes it less effective. So people with this variation, they present higher dopamine availability. So we classified our volunteers based on carriers or not carriers of the MET allele of the gene CONT.
Okay.
And what we saw when we started looking for the active group who received the real tDCS, we saw that there was a subgroup of the non-MET carriers that was responsible for this paradoxical effect. So this specific group of volunteers, they represent the group that regained 19% of weight at 12 months follow-up. And when I look at the appetite results of our trial, it's very interesting. During the intervention, we also saw a paradoxical effect. So tDCS has beneficial effects for the MET carriers of the gene CONT. So they showed reduced levels of appetite, reduced levels of hunger, desire to eat, prospective consumption over time. Instead, the non-carriers of MET, they showed higher levels of appetite. So they present higher hunger and desire to eat, showing a very clear paradoxical effect of the tDCS when you are looking for the variation regarding the genotype. So,
So just to be clear, the carriers of this form of COMT have higher synaptic dopamine levels, we think, because degradation is impaired in these individuals. Is that right?
Yes, right. So individuals who has this variation of this polymorphism, the enzyme that is related with the degradation of dopamine, that's what they call O-methyltransferase, it's less active. So once they have an impairment, they have like higher availability of dopamine.
Right. And in these individuals, the neurostimulation seemed to have a paradoxical effect in that it actually increased or didn't reduce appetite or increase appetite relative to the control group or the group that doesn't have this form of COMT. Is that right?
So the group that showed this polymorphism is related with the MET carriers. They show less levels of appetite. So they respond better.
Right. So and how do we understand that? Is that because they're already rewarding themselves? So by having high dopamine levels, or and therefore, you know, they don't need to reward themselves with food or something? What is there? Can we factor this into the sort of dopamine hypothesis?
Perfect. So this is related to the inverted U curve when you see at the low and higher levels of dopamine. So these individuals seems to have a beneficial effect of these higher levels of dopamine and respond better to the tDCS intervention. So the mechanisms underlying these results is still unclear. I think we need more studies looking at mechanicists studies, also looking at brain images that we can see, like now MRI, that we could try to understand.
Because the COMT and in particular this form of COMT, this is not the only context in which it has been implicated in perhaps having a causal role for important behavioral differences. Is that correct? What kind of other sort of traits, behavioral traits, has this been associated with?
Yeah, I mean, we studied just this genetic polymorphism, but we know that there are other genetic factors that can affect eating behavior. So I think we also need to explore and try to understand better which factors can affect neuromodulation, tDCS. But I think this is the first step that have been shown responds to the high variability between individuals and helps us to understand why some people respond to tDCS intervention and other people don't. So this is what we see in the literature, but we do not understand why. So why it might be may benefit some individuals and not for all the individuals.
Right.
So this, I think, it's the insight that we need to start looking at the genotype or other factors, neurotransmitter. Here we are talking just about dopamine, but you know that there are others, catecholamines, also involved in the eating behavior control. Eating behavior is very complex. It involves integration of homeostatic and non-homeostatic regulatory pathways. So, and in research, we see studies studying both mechanisms, but not integrating all these mechanisms in the study. So I think we need to look at this integration to try to better understand this complexity and try to give answers to show who are people who can really benefit for this intervention. Because regarding any therapy, we see that they might be not good for everybody. So, for example, one diet can be good for one person, then can be harmful for another. So it really depends on the individual level. I think we need to start looking at the individual level to try to answer, okay, who are the persons who tDCS could be benefit. So tDCS is a very attractive technique to modulate the brain activity. I think it's fascinating, but I think we need to try to look at these studies looking And this field to try to give this answer and
Yeah.
understand better the mechanisms and trying to see. For example, we see that individuals with obesity, they show a decreased activity in the prefrontal cortex. But there's also other networks that we have in pairs. So I think we need to try to understand better to figure out the target that we are going to.
Yeah,
Also a question.
fascinating. Yeah.
Exactly. Which is the target? Which is the right protocol?
Yeah, and we meant, yeah, which is the right protocol, because one of the things I've noticed is that we sort of glided over what sort of the transcranial, the exact form of stimulation is here, and presumably this is there's there are many different ways that you could deliver this therapy. I mean, not just the anatomical location. You've mentioned there's a dorsolateral prefrontal cortex, but that's a fairly large piece of neural tissue. You could deliver it posteriorly, anteriorly, more laterally, I presume. Are there different? What's the kind of level of parameterization here? Are there really millions of different ways in which this could be delivered? Because I guess one possibility might be that someone could argue, well, for certain with certain forms of COMT, this protocol that you followed is effective. But actually, if you'd taken another protocol, it wouldn't have been effective for that group, and we would have seen the inverse with the other group. So all we're really seeing here is not that one group gets effective treatment from neurostimulation, but gets effective treatment from neurostimulation according to this protocol.
Exactly, Jonathan. I think this is how we need to think, and then how we need to plan the future studies to try to give these answers, and then to safely and effectively prescribe DCS to the right person using the right protocol. So nowadays we see protocols varying from the time of the current, so varying from 20 to 40 minutes. So we apply 30 minutes of tDCS. Some studies are looking for doing a nodal or a cathodal tDCS over the F3 or F4, looking at the 1020 international system. So yeah, there's not like a pattern. Like we see different protocols during the research. So this is also difficult to do a meta-analysis and also to try to analyze the available data.
Are there any prospects for doing something sort of adaptive transcranial stimulation? Is that something that's being explored? Is there a way that we can sort of feed back and update the way that the stimulation is being delivered? Much as you're probably familiar in adaptive deep brain stimulation, there's a new generation of stimulators that are also sensing. And one of the hopes, although we've yet to see whether or not it's true, is that we can use the local field potentials as a feedback signal in order to optimize the parameters. I mean, in particular, for more complex, as it were, diseases like neuropsychiatric conditions, which don't seem to be amenable to treatment with simple protocols that we found were successful in Parkinson's disease or essential tremor. Is something like that happening in non-invasive transcranial stimulation?
Yeah, there are a few studies looking at also TMS, most like non-invasive neuromodulation, that show improved symptoms. Also, they are looking at the dorsolateral prefrontal cortex. So yes, we're still like trying to understand which is the better non-invasive strategy, and also trying to figure out the best protocol to see these results. So there is a very interesting study published in 2015 that they also used tDCS looking at the left dorsolateral prefrontal cortex. So the volunteers, they was admitted in an inpatient setting, and then they was exposed to a vending machine. They have ad libitum access to food 23 hours, 23.5 hours a day. And so they look at, after 3 sections just of tDCS, the researchers could see that the volunteer, that the patients in this inpatient setting, they have a significant reduction of body weight over a week, and also consumed less fat and less soda, and also fewer calories. So it seems to be a very interesting strategy. So I think you just need to look at like studies looking at more long-time studies. So definitely need to look at this long-term studies. Also looking at different group ages. So for example, different groups related with age, and also different classes of BMI, and also gender. Most of the studies are conducted with women, or I think to generate this to the population, and is also to investigate other subgroups of population, but also considering the variability. There is a meta-analysis that says that we do not have enough evidence, also, of course, because tDCS is a very well-known technique, very well-studied technique that has been shown with results to depression and neuropsychiatric disorders. But in the field of obesity, the investigation of tDCS in the field of obesity is more recent. When I started my postdoc studying tDCS in neuromodulation in 2016, there was just 10 published studies in the world. So I think,
really?
Yeah, wow. So I think it's a very experimental, but I see a potential of the technique. They just need to continue study and trying to give these answers regarding mechanisms and regarding long-term effects to try to figure out who are the patients who can really benefit of this technique.
One of the things I was wondering when I was reading this was you know, I guess the sort of paradoxical result that you've got is much more interesting than just a negative result, right? And one of the contexts I was thinking of was, well, this is a study looking in particular at obese people, but what about people that are under eating and have eating disorders? I mean, is there a prospect for applying this kind of technique to people that are suffering from anorexia or bulimia?
Yeah, there are already a few studies published with anorexia and bulimia showing good results, and also because it is related also with impairments of behavior related to food control. So yes, we have a study with anorexia using TMS showing potential results, and also with bulimia working with tDCS. So yes. There are just one study published last year also investigating people with severe obesity, higher levels of BMI up to 40. And now we are planning to conduct a study also investigating those subgroup of people with higher levels of BMI, because these patients has fewer options of treatment comparing with other classes of BMI. So we are starting looking at...
unpack that for me a bit. Why have they got fewer options, people with a very high BMI?
Yes, because our patients, for example, with BMI 60, 70, they, for example, surgical is not an intervention that...
Right, okay, okay.
People. So that's why, I think. And also it's even more challenging for them exercising. And
gotcha, it makes sense when you think about it,
exactly.
Of course.
Doing lifestyle modification is even more challenging for this group with very higher levels of appetite. And we have studies with computational modeling supporting the use of standard tDCS, dosing and parameters for people with higher levels of BMI. So that's why we are start thinking about studying these patients.
Yeah, and are there any downsides to this? I mean, we're sort of trying to work out how to make it work. Is there any suggestion? What are the possible negative effects of this? Do we know of any? Is there a prospect of any? Is there even a theoretical reason for believing that there would be sort of deleterious side effects, negative side effects?
For tDCS?
Yeah.
No, tDCS is very safe. It actually has a lot of advantages. It's very safe and portable. It's easy to apply. We are thinking about a low-cost therapy. If really could be new therapy for the treatment of obesity. We are talking about something that's very affordable. And also, I think the most adverse effect is skin redness. This is what we really see when we apply tDCS.
Gotcha. But this could potentially be a sort of consumer device that people can buy from the chemist, maybe even without a prescription ultimately, in terms of its potential.
Oh, yeah, of course. Yeah, we need to take care about this. This is a very important topic question, because we have seen like devices being developed, like a cap that people could put in, like at home. So I think, yeah, we need supervision, we need to take care. And actually also, for example, this study showing this paradoxical effect show that it can be harmful for some groups.
For the wrong people.
Exactly. It can be a benefit, but also could be harmful for certain subgroups of people that we still need to investigate and try to give these answers. I think this is the first insight, but I guess we are in the way of figuring out this for the next years.
Brilliant. All right, Priscila, I'm afraid we've reached the end of our allotted time, but it has been fascinating to hear about this research. And you've also mentioned some other studies that I'll certainly be looking up, and some other applications to this technology. And we look forward to seeing what your next contribution to this expanding field is. And so, yeah, thank you very much, and all the best.
Thanks, Jonathan.